Hello, thank you for joining me today. My name is Megan Warner. I'm affiliated with Rady Children's Hospital and the University of California, San Diego. Today we're going to talk about sleep disturbances in children with COVID. I have no financial disclosures or conflict of interest. And let's dive in. So PAS stands for post-acute sequelae, a severe acute respiratory syndrome coronavirus 2 infection. So according to the CDC, PASC refers to ongoing, relapsing, or new symptoms or other health effects occurring after the acute phase of SARS-CoV-2 infection that is present 4 or more weeks after the acute infection. So as we are all well aware, this definition is still evolving, and it may vary based on what source you are referring to. For the sake of this presentation, we will use this definition, especially in reference to the present 4 or more weeks after the acute infection. We are also seeing new terms, new definition, new information coming out. In the realm of sleep, coronasomnia or COVID-somnia has been proposed to encompass the constellation of symptoms of sleep dysfunction. There is a variety of the published information relating to changes in sleep among various populations in the context of COVID-19, but the long-term implications are unknown, especially in pediatrics. For this analysis, we use self-reported surveys from the Recover research study, which was conducted locally at our site between July 2022 and April 2024. The overall goal of Recover is to improve our understanding of recovery after SARS-CoV-2 infection with a focus on the prevalence, natural history, and pathogenesis of PASC in children and young adults. For the sake of our cohort, we only analyzed and enrolled participants aged 0 to 26, but this is a nationwide study that enrolls both adults and pediatrics. Successful completion of this study should lead to formal characterization of pediatric PASC as its own syndrome, and this is essential to develop diagnostic treatment and preventative strategies. For our methods, we self-administered surveys. So if you were under the age of 18, we did have caregiver reported these surveys. And if you were 12 years or older, an adolescent, we encouraged your input when answering these. We enrolled 762 patients, with 142 being non-infected and 623 being infected. These surveys were administered at 3 different time points, the first being at baseline before COVID, next being acute COVID, so during the active infection, and lastly being past, so that 4+ weeks after their COVID infection. Based on when you were enrolled, that's when you were administered the survey, so there could be some recall bias. We aim to evaluate the prevalence of sleep disturbances related to PASC in children, as our understanding of its impact on this specific population is currently limited. I will draw your attention to Table 1, which is our demographics for our 762 participants. As you can see, 67% of our population identified as Hispanic. This is very relevant, as we are seeing Hispanics are specifically getting a high rate of COVID infection, and the literature is not appropriately covering this. We can also see that our mean age was 10 in both our COVID and our control cohorts, and we also have our breakdown of our female and male population. For our results, we use odd ratios for statistical analysis. For these next couple of slides, I want to draw your attention to the x-axis and it changing based on the probability of each symptom occurring. For trouble sleeping, our baseline versus acute COVID was statistically significant with an odd ratio of 5.64. Our baseline versus PASC was also significant with an odd ratio of 2.71. Our PASC infected versus non-infected was 1.68, and this is our only non-statistical significant data point. Next, we have feeling sleepy. So our baseline versus acute COVID was 33.12. Our baseline versus PASC was 5.32. And our PASC infected versus non-infected was 3.12. Again, all three data points for feeling sleepy were statistically significant. Next, we have our odd ratio for feeling tired. Our baseline versus COVID acute was 21.65. Our baseline versus PASC was 4, and our PASC infected versus non-infected was 5.13. Again, all of these statistically significant. And finally, we have our odd ratio for nightmares. For baseline versus acute, we had 2.73. For our baseline versus PASC, we had 2.31. And lastly, we had our PASC infected versus non-infected, which was 2.63. All of these were statistically significant, which especially we attenuate in PASC, but all still significant. The variability when explaining the active infection could be due to the recall bias. Overall, children with COVID-19 infection exhibit a significant rise in sleep disturbance. These disturbances peaked during the acute phase, but most remain elevated compared to control groups, emphasizing that sleep disturbances are a key component to PASC. These findings underscore the significance of monitoring and addressing sleep issues, specifically in children dealing with long COVID. We do have some limitations. So our first one is the retroactive symptom recall, which I mentioned earlier, which did associate to when the participant was enrolled, which potentially introduced recall bias. Next, our constraint was our sample size, as we only utilized our site's data, which lacked sufficient power for multivariate analysis. Lastly, infected and unaffected groups were subject to misclassification, as our participants were not required to test. Keeping all that in mind, in the future, we do hope to incorporate the national level data to get the sample size and the analytical robustness. As mentioned, this is a nationwide study all the way Hawaii to the East Coast, and it has almost 40,000 participants, so there will be lots of data coming soon. We also hope to utilize antibody tests to confirm COVID infection. In the future, we also hope to analyze the potential impact of sex, age, ethnicity, and socioeconomic status on these findings. Thank you so much for joining my talk today. I would also like to thank my main investigators, Dr. Bhattacharjee, Dr. Tantasira, Dr. Ree, and the rest of our study team, as well as all the families that have participated this far. This is also an NIH-funded grant. Thank you so much for joining me today.